Somebody has two devices kept together.
LBK can join. LBK Sriram is sharing. You come. Yeah. LBK, you can unmute and we can start. Who's taking up the first case? Sachin, no?
Ma'am, Ashwin. I'm Dr. Ashwin from Madras MMC, ma'am.
No, who is taking up the first case for discussion?
As per your
We
list,
have the names, no?
as per your list, Ashwin is the first person. Ashwin MMC, no?
Yeah, so you can take up.
Ashwin has logged in from Sachin Chakravarti's
Yes.
system. Right?
Yes, sir.
Right, fine. Yeah. You can take up. Your DM hepatology or gastro?
The hepatology,
Okay,
ma'am.
fine. Okay. So LBK, you can start.
Yeah, please. Can go ahead with this case.
Yeah.
Somebody is sharing the slides, man.
Yes.
Yeah, Sriram
Yeah.
is doing
Yes,
it. Sriram is doing it.
43-year-old, good evening, sir. 43-year-old female patient presented with itching all over the body for past 2 years, predominantly over the hands and legs during the night, aggravated since 1 week. Yellowish discoloration of urine for past 1 week, bilateral pedal edema for 1 week, excessive hair fall for 1 week, easy fatigability, myalgia for 1 week, low-grade fever for 1 week.
Yeah. Any other questions you need from her
What are the
before we go to the next slide? So now here is a patient who has come itching all over the body for 2 years, predominantly over hands, especially in the nights. Aggravated since 1 week and dysentery urine for 1 week.
Whether the pruritus is hepatic or non-hepatic, whether associated with any comorbidities
Anybody?
such as diabetes.
Yeah. So you wanted whether it's diabetes. So she's not a diabetic. Okay.
Chronic kidney disease.
No history of
Chronic
chronic
disease.
disease.
Yeah. With,
Any associated rash? Does she have a rash? No. So that's another thing you need to ask whether it was associated with a rash. No rash.
Yes.
Okay.
and associated whether the itching during that time any history of easy fatigability is there.
No, other thing is the itching is more nocturnal.
Yes, sir.
They have said during the night is more, but we need to check whether it's more on the nocturnal. Where all do you get nocturnal itching and liver disease? What is a classic example of nocturnal itching and liver disease?
During worm infestation, sir. Nocturnal itching.
liver disease?
Nocturnal itching and liver disease.
Liver disease.
Most classical
Simple,
intrahepatic cholestasis of pregnancy.
ICP.
Intra-Hepatic cholestasis of pregnancy generally starts with soles and palms and then goes up very much in the night. That's number 2.
In
Which other liver disease at 43 years can come with predominantly itching as a predominant symptom
Female patient.
in a female patient?
PBC,
Primary biliary.
there is cirrhosis.
What do we call these days?
Primary biliary cholangitis.
Primary biliary cholangitis is a new entity. The EASE has come down with the recent guidelines on cholangitis and still using going to go through. So this is primary biliary cholangitis. Then
Second will be autoimmune hepatitis.
third,
Second will
Not
be
autoimmune
Autoimmune
hepatitis does not come. Autoimmune hepatitis does not come with itching.
with overlap, sir. Autoimmune
The
hepatitis
overlap
with
or
overlap.
autoimmune cholangiopathy can come. Or autoimmune cholangiopathy can come. 4.
third, primary sclerosing cholangitis will be,
Okay.
but
PSC.
it is more common in males.
That is okay. PSC can also come in females. Then
Fourth, any drug-induced liver
very
injury,
good.
sir.
Drug-induced cholangitis.
IgG4, any of these cholangiopaths?
IgG4. IgG4 disease. This
IgG4
is all
IgG4 is,
you need to think about. Okay.
yes, sir. With
Okay.
viral,
She has been having for 2 years of itching, and then jaundice for 1 week.
yes, sir. Yellow discoloration of urine for 1 week. I want to know the onset, character, and progression, sir.
Onset means what you want.
Whether it is insidious or
No, yellow discoloration is only for 1 week.
whether yellow discoloration of urine
No,
with
doctor, yellow discoloration is
lice,
only for
whether-
1 week. 1 week cannot become insidious. What do you want to know in this 1 week?
whether it has increased in severity.
Is it the onset of
Intensified.
prodrome? No. Is it onset of prodrome? How do you know this is not an acute viral hepatitis? So the most important thing, is there any associated prodrome? First of all.
Prodrome.
So is there a prodrome in this patient or not? So that is what is most important here. I think.
Okay, sir.
So in this
The
patient,
drug-induced
you have to
hepatitis will always mimic an acute viral hepatitis.
Yes, sir.
Okay, so here your question will be: is there any prodrome? Okay. So classical is you should ask any patient, did you have any fever before the onset, any nausea, any vomiting, all those things. Okay.
So in any patient, when you have, so try to, one is linking the itching with the jaundice, the other one is the two being totally unrelated. No? It's possible that the two are totally unrelated. So keep that in mind. All cases that we see may not be always liver disease. So just keep the two total distinct characteristics, okay? So one is itching, primary, patient is having itching for a long time, maybe she's got allergy to something. And jaundice, something has happened with edema leg, no? And the fatigue, everything is all acute and also with fever. So what are the few questions that sir would like you to would you like to ask?
The prodrome was there. So okay, so there was no prodrome,
One is
and she just noticed yellow discoloration of urine for 1 week. She's got bilateral pedal edema for 1 week.
Any associated abdominal distension?
She said only bilateral pedal edema. There was no abdominal distension, but she noticed this along with the yellowish discoloration of urine for 1 week. Okay.
Any history of abdominal?
Therefore, and easy fatigability and myalgia. And she had a low-grade fever for 1 week. So it was not a classical prodrome, but she presented with a low-grade fever, yellowish discoloration, and yellowish discoloration and low-grade fever. Yeah, this is what she did.
all have come simultaneously, no? So what are the other things that you would like
Everything
to
has
ask?
come for 1 week. So that means there is some sort of an acute onset of jaundice with yellowish discoloration. But only thing is very unusual in an acute hepatitis to come with a bilateral pedal edema. So somebody has got itching for 2 years and has an LOL for 1 week and has a bilateral pedal edema, excessive hair fall, easy fatigability. What do you think she might have?
Mainly autoimmune related cholestasis, such as
No, she might have an underlying chronic liver disease which is going on with pruritus for 2 years. Now she has developed jaundice and pedal edema has almost come immediately. Okay. So that means it's probably an acute on some chronic liver disease. Okay.
yes, sir.
Acute on some chronic liver disease. Because pedal edema, but she has been having fatigability and myalgia for 1 week. So your question should be whether for the last 2 years Is she associated with any easy fatigability?
Dams.
Or which has been going on for 2 years is your question. You get my point?
PT,
Yes, sir. Any? I want to also ask about any history of abdominal pain or any abdominal surgery.
Can we go to the next slide? Can we go to the next slide?
No history of yellowish discoloration of eyes
Previously or
colored
clay
stool.
colored stool? Yeah.
and
No,
don't keep saying no history, just say no, don't keep saying so. GI bleed, abdominal distension,
No
oliguria,
history of GI bleed, abdominal distension, oliguria, abdominal pain, vomiting,
yeah.
loss of appetite, loss of weight, breathlessness, chest pain and palpitations, altered sensorium, altered sleep cycle, any associated history of CAM intake, malar rash, photosensitivity and oral ulcers.
So yeah.
So, yeah. So basically, she didn't have any abdominal pain. She didn't have any abdominal distension. She always feel little fatigability, and she was told that she was always anemic. Okay, anemic. This is what has been her main symptom. So she's been having, say, some itching, and she was told that her hemoglobin is always low for the last 2 years, and recently she was found to be jaundice with pedal edema, and that's what she has presented to us. The only go ahead. Can we have the next slide?
I want to also ask any history of any hyperpigmentation of the legs or associated
No.
vitamin.
No hyperpigmentation. She noticed some alopecia. There was no rash, itching, but there was no hyperpigmentation of the either the hands or the legs.
Any
history
history
of
of
C-section.
history of
She has history of blood transfusion 4 years back because she found to be anemic.
and no
So now link up. What's your
Can you link up now? History of blood transfusion 4 years
now
back.
link up the anemia, link up the anemia, edema, onset itching, jaundice, and then there's also history of anemia, fatigability is there. Now try to link up. When can get an anemia in such context like this with jaundice?
Eating for 2 years, she is anemic. Had a blood transfusion 4 years back. Now for last 1 week, she has come with jaundice and pedal edema. There is
Which
no
means
abdominal distension. There is no this one. There is no evidence of it.
So anemia has almost preceded the onset of pruritus, right?
Anemia preceded. Anemia was there.
Anemia has
right
preceded.
now. Yeah. And we need to ask whether she had any other menstrual irregularities for which sort of a contributed to anemia. Okay, these are the symptoms which you need to ask. Dr. Varghese, sir, you want to add on anything?
No, I think the initial part has been well described. Only thing that when a similar case comes, we have to think of related and unrelated. Both has to be there to begin with, whether it is liver related, liver unrelated. And the final part, whether she has jaundice and pedal edema, this again can be considered as related and again unrelated. So the initial part of the discussion, our differential diagnosis should be wide, and then we try to connect as much points as possible and narrow down the differential diagnosis and try to arrive at a correct diagnosis. That would be the approach. I think every aspect has been covered. Only thing is that when she developed jaundice recently, you asked about the prodromal symptoms. Did pruritus change? Whether any other rash developed? Was that this is the first time that pedal edema occurred? And he has rightly said about abdominal distension. So most of the points have been already covered. Okay.
So what are the possibilities at the juncture? Anything else you want to know?
Oh.
Comorbidity, you'd like to know?
Yes, sir.
Why is it important?
Any diabetes?
Or
There was no CAM intake.
why is it
What is
important?
other?
Diabetics.
Antihypertensives, antituberculous, comorbidity is very important, no? You'll
Yes.
get some information on the drugs because we're not hitting anywhere. We're not here to get what's the cause of pruritus and then followed by this jaundice edema, and there's an anemia in the background. So you need to know family history. You need to know of anemia.
Yes, ma'am.
Family history of anemia is important. There are a lot of Hal minors around. Okay. And then, or it can just be a chronic liver disease with hypersplenism. And some fellow would have seen 7.5 grams per deciliter and given 2 units. So it may be again related to liver disease. Or it may be, so what is the cause of anemia? What crosses your mind in this context? Hemolytic, no?
Anemia,
Autoimmune,
autoimmune
exactly.
hepatitis with overlap present with
Let's not discuss about autoimmune hepatitis. No? Just think that there could be an hemolytic anemia. So that is important. No? Thyroid. Then you look
Cause anemia in a liver disease.
Sir, most common cause is iron deficiency anemia, followed by second
Why
is
do you get iron
GI
deficiency?
loss.
Situations where you get iron deficiency.
in chronic liver disease, you get iron deficiency.
In liver disease.
Microcytic hypochromic anemia. Second is
How
GI
do
blood
you
loss.
get microcytic
GI
blood loss? GI blood loss due to
portal esophageal varices, sir. Esophageal varices, bleeding, acute varicose.
On bleeding to produce anemia. She never had a GI.
It's chronic anemia. No?
She had no
It's chronic
hepatitis. She had
anemia.
no melena. So in liver disease, if you say there's iron deficiency anemia, what would be the cause for iron deficiency anemia?
Apart from vessels, what are other changes that can take place?
There can be B12 deficiency.
No, they can be portal hypertensive gastropathy.
Portal hypertensive gastropathy.
With gastric vascular antral vasculoctasia, which can bleed slowly. You can have telangiectasis due to portal hypertensive enteropathy. You can have portal colopathy, which can all slowly bleed and produce. Varices do not produce slow bleeding.
Okay.
So one is iron deficiency.
Second is in Wilson's, there can be hemolytic anemia.
Wilson's can have Coombs positive.
In Coombs negative, Wilson's Coombs positive, we have to suspect autoimmune hepatitis.
Okay. Then where do you get Spursell anemia?
Sieves syndrome. And alcoholics can.
Sieves syndrome is hemolysis.
Hemolytic
Chronic
anemia.
alcoholism produce what sort of anemia?
Chronic alcoholism can cause a macrocytic anemia. Secondary to B12 deficiency and direct bone marrow suppression and
No, that is acute alcoholic hepatitis. Will produce bone marrow suppression. Generally, chronic alcoholism or alcohol use disorder can produce folate deficiency and renal deficiency. Okay. What is a Spursell anemia? Where do you get Spursell
What is
anemia?
Spursell?
In chronic liver disease, you can get Spursell anemia, where they form a lot of acanthocytes which can get destroyed. The most common cause of anemia and portal hypertension will be hypersplenism. So this is how the anemia. So okay. So she had anemia for a long time. Then she has had a blood transfusion. Now she had pruritus for 2 years, and now suddenly she has got jaundice and biliary.
Is there any more in the history, or we can give her differentials now? Starting differentials.
Can we have next slide? Yeah, I think.
Okay.
Yeah.
This.
Past history. 4 years back, she had an episode of jaundice, anemia with a positive ANA, managed with a
ANA? Immunofluorescence.
Managed with the blood transfusion. She has undergone a keratoconus surgery in February 2022 and was on topical steroids. For the above complaints, she was evaluated outside, ultrasound abdomen done. It showed coarse echo texture of the liver with splenomegaly, and patient referred here for further management.
now you can give your differentials.
First, summarize.
Summarize and give a differentials.
63-year-old female with history of
43 years.
provide
43 years. 43 years. You tell
43.
Yeah.
43-year-old female with a history of pruritus over the palms and soles for 2 years, with a history of sudden onset uh, uh, painless jaundice with anorexia and with prodromal symptoms for 1 week, associated with low-grade fever, with past history of blood transfusion and pedal edema for 1 week, with past history of blood transfusion, with prior history of jaundice and anemia, with positive ANA 4 years back, with the history of surgery.
What surgery is that?
Keratoconus surgery, with the history of keratoconus surgery in February 2022.
What is keratoconus?
It is
How does it appear? Conus is conus, keratosis.
Where is keratoconus?
Then we can just move on. You can just tell them.
Keratoconus is a completely abnormal something of the cornea thing. So she is going to be on topical steroids. Okay. So she had a keratoconus surgery now, but at that during that point of time, she was found to be. So here is a lady who has had pruritus for 2 years. Jaundice, she was found to have some mild jaundice and anemia with a positive ANIF, and she was given blood transfusion. All the while, then following which she said she was relatively asymptomatic. So positive ANIF, jaundice and anemia could have been
autoimmune.
what is the possibility of jaundice, anemia, and positive ANIF 4 years back?
It can be due to autoimmune hepatitis.
Could have had an autoimmune?
Overlap.
Autoimmune?
Monitoring.
Autoimmune.
Could have had autoimmune hemolytic anemia. Jaundice could have been due to
Secondary gallstones.
doctor. When you have one autoimmune hemolytic anemia, can hemolysis produce jaundice?
Yes, sir.
Jaundice could have been due to autoimmune hemolytic. She could have had indirect, we don't know. She could have had an indirect hyperbilirimia due to an autoimmune hemolytic anemia. Or she could have an associated autoimmune
Hepatitis. Okay, sir.
hepatitis. And she said she was treated with some medications. Possibly she would have had been treated with some steroids and she could have become better, isn't it? But she's been having pruritus for nearly 2 years. And she has received a blood transfusion 4 years back, and now she comes with jaundice of 1 week duration associated with pedal edema. So, what are the possibilities she has now?
And you have an information that there's some coarse echo texture.
Ultrasound shows coarse echo with splenomegaly.
Methylsphenomegaly.
My syndrome will be in intra-hepatic cholestasis, ma'am. My first differentials will be autoimmune hepatitis with the overlap. Second differential diagnosis will be primary biliary cholangitis. Third differential diagnosis will be chronic viral hepatitis. And
what is chronic viral
diagnosis?
hepatitis? What is this chronic viral hepatitis?
Because
is there any term like that? Is there any terminology, doctor, like chronic viral hepatitis?
Here, patient has got already some sort of a coarse liver with splenomegaly. So, the first thing is she could have had an autoimmune INA-IF positive autoimmune hemolytic anemia. I agree it could be autoimmune hepatitis. And now probably she was steroids earlier. Now she would have had a recurrence of autoimmune hepatitis. Since the ultrasound shows already cirrhosis of liver, that means she has got autoimmune hepatitis on a pre-existing. So she could have a reactivation of AIH on a pre-existing chronic liver disease.
Yes, sir.
Could have a flare. What
Flare
else
of
can you
AIH.
think of? Somebody comes with itching,
Fourth,
cholestatic symptom, 4 years
Fourth.
blood transfusion, and jaundice. No. Hepatitis B, can it produce pruritus?
yes, sir.
Chronic hepatitis B can produce pruritus.
More common with hepatitis C, sir. B is less common.
Yeah. So you need to think of hepatitis C also in this patient. Chronic hepatitis C. Okay.
Yes, sir.
Chronic hepatitis C is one more thing which can cause symptoms like this. Then
Sir, it can be
you said
also
primary
biliary cirrhosis, sir. Biliary cholangitis, sir. Primary biliary cholangitis.
biliary cholangitis.
And last differential diagnosis will last two differentials will be primary sclerosing cholangitis, and last will be drug-induced liver injury.
Primary sclerosing cholangitis will never come to you with pruritus preceding jaundice.
Okay, sir.
Preceding jaundice. Okay.
Okay, sir. That's why I
Preceding
kept
jaundice.
last
It comes
differential.
it comes with this one and this paper don't present. But here the patient has been having jaundice for nearly pruritus for 2 years.
And last
Or she can have pruritus due to
drug-induced liver injury.
there's no history of CAM. There's no history of CAM. There's no history of any other drug. She has been taking only topical steroids for keratoconus. And probably 4 years back, she was treated for some time the jaundice. After that, she's been having only pruritus and so it could be an autoimmune hepatitis with a flare. She may have a chronic HCV, or she may have autoimmune hepatitis with the overlap, or it can maybe primary biliary cholangitis. Okay. Or
Is it possible that
the pruritus can be due to chronic anemia, and she may have some other liver disease, isn't it? When somebody is anemic, they can always have pruritus. So sometimes anemia can produce pruritus. So this is a possibility. So that she may have some other liver disease, like a Nash or something.
Is it possible that she has cholangiocarcinoma now? Because there's a sudden failure. And is it possible that she actually had an overlap, predominant PSC and less of AIH? Depending on which is more dominant. And there's a sudden failure now. Is it possible that should be having a higher cholangiocarcinoma or intra-hepatic cholangiocarcinoma? Not intra-hepatic, cholangiocarcinoma. I think that also should keep in mind because there's a sudden failure, no? The sudden failure is the one that is making us think, is it B related, is it C related, or is it underlying liver disease, or she's developed diabetes or something? There's something that has happened to result in a failure.
Some other persons have asked for sarcoidosis. I think there's a possibility. Granulomatous liver disease is another possibility where you can keep having itch, and then probably now she could have had decompensation due to hepatic sarcoidosis. That's also a fairly good possibility. Okay. So maybe these are all
the other thing I was just thinking, if you just say, like take the physiology aspect of it, BSEP, it is bile salt export protein. The export protein that is involved, then you get pruritus as a first presentation.
Yes, ma'am.
That you get as the first presentation. So is it possible that she has something that is actually affecting that, like an ICP? And therefore the pruritus has come in ahead, and then she's developed chronic liver disease, and now she's gone in for a liver failure. You have to keep all these things in mind because it's pruritus. Pruritus is due to the BSEP.
Okay. Yes.
You take the export proteins, MRP2 is for bilirubin, BSEP is for the bile salt. And what we really find is when some of these patients, they take this alternative system of medicine and they will get stuck there. Either MRP2 is bilirubinostasis or they get stuck at the BSEP when they present with pruritus. So remember the receptor, something is wrong there, where the export protein is defective.
Okay.
Either there or is in the biliary system, canalicula, or in the intra-hepatic or extra-hepatic biliary system. So like PSC, PBC, and all these are predisposed to cholangiocarcinomas. So I think you should keep that in mind. Okay, we can move on. So examination.
On clinical examination, patient is conscious oriented, pallor present, icterus, patient is icteric, bilateral renal edema present.
VT, 1 minute,
No
1 minute. VT, any differentials you'd like to offer? VT?
Yeah, I think you have covered most of the differential diagnosis. And the point which you told that what has changed the natural history in the last 1 week, that's one thing which has to be thought of also. You considered supraorder infections, drugs, and cholangiocarcinoma also. So I think the factors which change the natural history in the last 1 or 2 weeks should be highlighted in this case. Yeah. Over to you.
No peripheral lymph nodes clubbing, alopecia present, platycynia present, BP is 110/80, pulse rate is 86 per minute, BMI is 23.7.
Okay, go ahead.
Per abdomen is soft, liver is just.
I think there's no. What are the important things that you look for in this polystatic, long-standing polystasis?
Ma'am, I would.
Something that you should highlight.
I'll look for the vitamin and
xanthomas, yeah, xanthomas.
Vitamin deficiency, xanthomas,
hyperpigmentation, clumping, resorption of nail bed, shiny nails, xanthomas. These are the things that should immediately suppose
Xanthelasma.
xanthomas. All these things you should keep in mind. Yeah. Okay. So examination of the liver is just palpable. Okay, move on.
Liver is palpable. Let me tell you, it is firm. It was quite a firm liver. The right lobe was much distinct on the right.
No free fluid, splenomegaly.
There was splenomegaly. There was a spleen which was palpable. There was no free fluid. The liver was palpable. It was quite firm. It was quite firm in consistency, especially the right lobe more than left. There was no free fluid in the abdomen. There were no dilated veins or any back veins. Okay.
So always look for thyroid gland. Examine the thyroid. Do a detailed examination for the anemia. Don't miss some, ulcers in the leg for sickle cell. Keep autoimmune hemolytic anemia is most likely, but just keep other hemolytic anemias also in mind. Okay.
And only other thing is you should also look for any notes.
Yeah, PFIC and DD, yes, it will, but only in the female patient. And pruritus, they present with jaundice. Jaundice is a feature of PFIC. Normally, they don't present with isolated pruritus. I have seen 2 or 3 cases of PFIC, but most of them are all the ones who present with jaundice. You agree to that, LPK? PFIC.
Madam, yeah. PFIC, they're present with jaundice and cholestasis.
Jaundice, yeah.
Then, any investigations? Okay. So at the end of the thing, she has got a firm liver. Splenomegaly is possible. She was quite palpable. She had a mild icteric. There were no dilated veins in the abdomen, no dilated veins in the back. And she had no free fluid. She had a pale edema. She was anemic. There were no nodes. One of the reasons for the nodes I looked out for is, apart from, we also considered IgG4 disease. So at that point of time, probably you need to think of, you need to look for nodes. Okay.
What about lymphoma, NVK? Lymphoma. Yeah, itching. They present with itching.
Lymphoma is another possibility. I'll tell you one thing, especially we had one lady who had come with small nodes and hepatomegaly. Actually, according to when we evaluating, when we had the monthly meeting, our oncologist was telling the small T-cell lymphomas can come very, very smolderingly. They'll just come with you nodes. After 1 year, then they develop a hepatomegaly like that. Something, as Madam said, this is also a possibility. So some infiltrative diseases like lymphoma or sarcoidosis is a possibility. And small T-cell lymphomas can initially come like a small nodes. The nodes will look very, very this one, but after some time, they grow over a period of 2 to 3 years, smoldering lymphomas. So that's what she was telling me the other day. So we need to keep in mind. This is something which we discussed in our tumor board the other day. Okay.
And histiocytosis. Some of these
All
plasma cell dyscrasias, some of these, cells which liberate certain things causing pruritus, and then they present as hematological disorder with a hepatosplenomegaly. I think you should keep. Okay, continue. So hemoglobin is 8.6.
Continue investigations.
Hemoglobin is
Next person. Who is the next person? Who else is participating along with who is the other person?
I'm participating.
Yeah. What's your name?
I'm Dr. Namit Reddy.
Okay, Dr. Reddy, you can just take over and both of you can interact.
Yes. Coming to the blood investigations, hemoglobin was 8.6, WBC 2800, neutrophil 41.9, eosinophil 6.8, MCV 76.9, platelets were 1.31 lakh, PTINR 1.11, GRBS was 128 mg per deciliter. The peripheral smear was showing pancytopenia, microcytic hypochromic anemia. CRP was negative, ESR was 6.
1 minute, just go back. So what is it basically? What's happening? There's a pancytopenia, no?
Yes, ma'am.
There's a more pancytopenia. INR is normal.
So what is it?
And eosinophil is 6.8%, slightly on higher side. And so what is it? Pancytopenia. So
Could
features
be
of
due to
pancytopenia.
what? We are asking what is it pancytopenia could be due to in this situation?
Hypersplenism. Yeah.
Most possibly could be hypersplenism.
It can also be bone marrow suppression, no?
Hemolysis.
Yeah, but hypersplenism usually have normocytic normochromic,
Anemia.
Yeah.
So more microcytic hyper.
Here is microcytic hyperchromic.
So bone marrow.
What's the explanation?
Bone marrow suppression do something. No? That can also cause pancytopenia. Okay.
So there must be
myelodysplastic,
one additional factor working as a cause of anemia. There should be another cause of anemia other than hypersplenism. It also could be there.
Yeah, myelodysplastic syndromes, myelofibrosis. Only thing on all those livers will be huge, no? You don't get such small livers.
You don't
Just
get
a small
you get huge spleen in that.
Yeah.
Spleen was moderately enlarged here. It was not. Okay. Can we go ahead? Next slide.
Go, next slide.
Total bilirubin 2.2, direct is 1.6, indirect 0.6, AST is 48, ALT 15, albumin 3.5, globulin 3.3, GGT is 81.
No, this actually 1 minute. This report was actually when she came to us in the OPD, she was sent with a bilirubin of 4.6. Direct of 2.8 and AST it was outside reports. AST was 115, ALT was 75. Of course, there was not much of an AG reversal. This was the report she came to us in the OPD. This was the report when she got admitted with us for some investigation. Okay.
Urea of 10, creatine 0.5, sodium 137, potassium of 3.5.
So no, next. So let's go back. Yeah. Next, go back. Yeah, keep this slide please on. So here, what is the interpretation here?
Direct hyperbilirubinemia is seen, sir.
AST was certainly more than ALT. And she had no, I think gamma GT was elevated according to our this one, and ALP was normal.
Yes.
Okay. Then what else you want now from now onwards? Mild hyperbilinemia, AST more than ALT, GGT elevated, ALP is this one.
Normal.
What do you need next? What is the other investigations you need from now onwards?
ANA, I would like to.
No. See, here is a patient who had a blood transfusion. What is the first thing you'll ask in a patient who comes with when she has got already an ultrasound which shows coarse liver, palpable firm liver, sphenomegaly? What will be the first thing?
Viral markers, my doctor.
Yeah.
What will you ask next of investigations in here?
Yeah.
Okay, let me ask you, between hepatitis B related chronic liver disease and autoimmune liver disease, which is statistically more?
Hepatitis B related.
Naturally, that's the next question you'll always think of is a chronic viral hepatitis.
Viral.
So you need to ask for hepatitis B, then
The hepatitis C.
so you ask for a viral serology, isn't it?
Serology.
That will be the most important thing which you need first. Okay, here, anything this thing, no? Because hepatitis C, hepatitis B, both can produce immune-mediated problems. You know that, no? You know all the extrahepatic manifestation of hepatitis C. You can have diabetes, you can have autoimmune features, you can have autoimmune hemolytic anemia, you can have type 2 diabetes mellitus, you can have lichen planus. Okay.
Yes.
All this can happen with this one. And even your ANA-IF can also be positive in chronic hepatitis C. The only way you differentiate if you have a chronic hepatitis C and ANA-IF positive, if your ANA-IF is less than 1 in 160, it is this is due to hepatitis C.
Yes.
But if your ANA-IF is more than 1 in 320, then that means you have an associated autoimmune thing. This is how you differentiate. This was first beautifully described by Michael Manns in a paper which was early as 1996. Okay, in Germany. This is what you differentiate. So you need to ask for hepatitis B, hepatitis C, and anti-HBC total. Can we have the next slide?
HBsAg negative, the anti-HCV antibodies negative, and HIV negative. The
Total anti-HBC was also negative. Okay, so now we routinely do that. So total anti-HBC was negative. Okay, next, what do you want?
autoimmune workup.
Can we go to the next slide, please? What is the anemia evaluation? Can you tell about the anemia evaluation here? Patient has had ANA-IF positive and she got anemia. Earlier ANA was positive anemia.
The reticulocyte count is 1.3. The vitamin B12 921. Folate is 14. Iron is 22 micrograms. Ferritin is 25. TIC is negative. Direct and LDH is 285.
So there was no obvious hemolysis. There is some mild iron deficiency anemia. Okay, and the bone marrow is not very active. Okay, it is not. This thing is 1.3, and your vitamin B12 is normal.
No, yes.
Which liver disease is associated with the low B12? Do you have any Indian data on that, please?
NCIPH.
Anybody can answer. Anybody can answer this.
Avan.
Related liver disease.
Non-cirrhotic intrahepatic portal hypertension. NCPH is one of Madhu's paper from CSC Vellore where they found well.
Yeah.
So please remember that NCPH is again a thrombotic condition. So you may have a lot of associated diseases like celiac disease. So here, this anemia shows that there is only an IDA. There is no hemolysis and B12 was normal. Can we go to the next slide?
The TSH is 2.5. Ceruloplasmin 25 milligram per deciliter, and the fasting lipid profile is normal.
Now somebody asked, can it be Wilson's? Wilson's is not a really presentation like this. But Wilson's, according to EASL guidelines, now can present at any age. So copper-related disease. Those who checked ceruloplasmin was 25. Fasting level was 9. TSH was okay.
What are the few things that are getting?
Urine examination is. Madam, go ahead, please.
What are the few things that are getting excluded by this discussion? What are the things that are getting excluded? Alphos normal. What are the things that are getting excluded? This thing is normal.
Any obstruction we can rule out, like.
Yeah, at least
No,
extra.
ultrasound abdomen earlier has not shown any biliary obstruction. So now ALP is normal means some of the cholestatic disorders will get excluded. In the list which Dr. Sachin had put, what can you exclude here?
PSC.
Primary sclerosing cholangitis and primary biliary cirrhosis would have got excluded because alphos are normal. Okay. Wilson's disease, very unlikely with 25. Viral serology is negative. Okay. Can you go to the next one?
The autoimmune marker. ANA-IF is positive. ANA profile. AMA is positive. Liver IgG profile negative. Serum IgG is
Liver IgG in our center will include LKM1, SMA, and this one, and LCA antibodies. Okay, and AMA M2 also comes into that.
serum IgG is 14.
Is it abnormal or normal? Serum IgG.
Elevated, sir.
What is the cutoff? Cutoff anything above 18 is abnormal. 14 is not elevated, it is normal. Anything above 16 to 18 was this thing. Serum IgG4 was normal, it was only 0.8.
Yes.
He recently brought the report, it was only 0.8. And we checked the anti-TPO antibodies as a part of autoimmune workup, that was normal. Here only AMA M2 was 2+ positive. Okay. So what is the situation now?
Intra-hepatic cholestasis with AMA M2 positive, PBC.
Maybe we are dealing with a primary biliary cholangitis. We can't still rule out any other infiltrative disease like sarcoid, but alkaline phosphatase is unusually low in the patient. That's what. Okay. Any other imaging you want? I think we went ahead with a CT, okay, just to see that if you're missing any other lesions in the liver. Remember, sometimes some of this patients can have infiltrative malignancies which can come like this, okay, and this is something which once I learned in a panel discussion by Julia Venden. Julia Venden is, I don't know whether you heard of Julia Venden. Julia Venden is one of the biggest intensive specialists. And she told in one panel case that this is nothing but malignancy, infiltrating malignancy. So that's why she always says in these cases, go ahead and do TT. Do we look for any lesions in the liver? Okay. So we went ahead and did a CT scan in this patient because in this patient, you can never rule out an infiltrative disease in a lady who has come with fatigability, jaundice, and firm liver. Okay.
Yes.
So infiltrative lesions could be granulomatous, it could be lymphoma. Granulomatous could be tuberculosis, could be sarcoidosis, many other things. It could be drug induced. And possibility is that you need to rule out a lymphoma lesion. Somebody asked about BCS. Yeah. Other thing, in every chronic liver disease, you have Budd-Chiari syndrome as a differential diagnosis. So we also do a CT to make sure. We suspected IgG4. IgG4 is normal here, But IgG4 will, apart from the liver, can also show many other organ involvement by CT scan. So we went ahead to the CT. Can we have the next slide? Of course, urine analysis we did only because she had pedal edema. So we do a complete urine examination. We took a urine PCR. There's nothing. So the pedal edema was not of renal origin. Okay. Sarcoidosis workup. Yes, calcium and ACE levels may be included in this. In this, ACE levels and sarcoidosis can be included in this. Yes.
But I would do those when the alphos is high, you know.
Alphos is high. We didn't do mainly because alphos.
If alphos and gamma GT is high, then yes, I'll consider.
Gamma GT is measured, alphos was. So the only we found was, and CT, what it showed?
Cirrhotic liver, sir. We can see.
Very minimal surface nodularity. There was no ascites, and liver showed some surface nodularity. And can we have the CT's report? We have some. They said just some surface nodularity of the liver, little bit of portal, dilated main portal vein. There was a reactal gallbladder wall thickening, and there was no SOL. Nothing is there. So we are now left with some chronic liver disease with possible portal hypertension, AMA M2 positive, and pruritus for 2 years. Once ANA IF positive, but here negative. Next, what do we do? We did endoscopy. What does endoscopy show? Can you show the endoscopy picture, please? The first picture is the esophagus, which doesn't show small varices, and there's a large fundal varix. Did you notice it?
Yes, sir.
And there was a portal hypertensive gastropathy. So she has some chronic liver disease, AMA M2 positive, SGOT is more than elevated, I think, mild, low platelet count. Okay, go ahead. What do you do next? What do you do next, doctor?
We may evaluate the cause. We may go ahead with a liver biopsy, sir. Maybe.
What sort of liver biopsy? You want a percutaneous?
LBK, you can just highlight on this clinically significant portal hypertension and discussion on that.
Madam?
Clinically significant portal hypertension, no? Now she'll have, because varices are present. So what do you expect the HVG
Varices are
in
present.
this patient?
So when the varices are present,
what do you think will be the HVG in this patient?
More than 10. It will be more than 10.
It will be more than 10 and less than, and less than? Less than 15, no? 15 is the time when they bleed.
Yes, yes.
Yeah. So what is subclinical? Subclinical is between
more
5
than
and
5
10.
and less than 10.
10.
Less than more than 5 and less than 10 is
this is what
is more than 10.
And this is what happens
And
in NCIPH.
anybody at 12, they will develop varices. Between 15 and 20, they may bleed.
Yes, sir.
So we went ahead with a liver biopsy in this patient. Somebody raised a hand. What is it? IgG4 I did not consider, mainly because the IgG4 levels are normal, 0.1%, and CT does not show any changes of IgG4 at all. IgG4 disease comes with severe pruritus, they come with jaundice, and also the IgG4 was absolutely normal. It was 0.1 micrograms, something like that. It was normal. So we didn't take any ampullary biopsies with it. And CT, if you look at IgG4 disease, we should have shown some bulky pancreas, sausage shape. You would have had nodes. You could have had thickening of the bile ducts. You can have something like an autoimmune pancreatitis, like you have a sausage shaped pancreas. You can have multiple nodes. You can have diffuse thickening of the bile duct and diffuse thickening of the gallbladder. So CT did not show all those things except some reactive thickening of the gallbladder wall. IgG4 we did not really consider. And IgG4 people really come a little sick actually. So we did a liver biopsy next because we thought probably with the pruritus, AMA M2 positive, chronic liver disease, probably we are dealing with a primary biliary cholangitis.
What do you expect in a PBC? Dr. Reddy.
Intra-hepatic biliary disruption.
What disruption?
You will expect a canalicular cholestasis. You will expect bile duct proliferation. What are the classical things what you will find in biliary cholangitis?
Ashwin?
Yes, ma'am. We get florid ductal lesion. Second, interface hepatitis. Third stage, we may get
Interface hepatitis. You will get only if you have an associated autoimmune hepatitis.
Autoimmune
With only
hepatitis.
PBC, you will have a florid bile duct lesions. Then you will get granulomas, isn't it?
granuloma. In
And you
advanced
will have
stage,
lot
it
of
may go for fibrosis and cirrhosis.
lymphocyte plasma cells in the bile duct, and there will be evidence of fibrosis. Okay.
Okay.
So what do you see here?
Ballonic.
What do you see here in the biopsy first?
What is glaring?
What is glaring at you?
Ballonic
What is
disease.
glaring at you? Ballonic there, we have to look for it, man. What is glaring at you here?
Fat
What are
globule.
those?
What are the white things? Huh? Yeah, the accumulation of fat. No, there's severe steatosis in this patient, and you can see the nuclei are pushed to one side, isn't it? To almost.
You don't use it. 1 minute. You don't use the word fat globule, okay? It's a steatosis.
You use steatosis. So when you have steatosis, you need to see whether then when your steatosis is there, you should see whether it is only pure steatosis alone or you have steatohepatitis. Can we have the next slide?
How much of fat can be normally present? How much of fat can normally be present? Ashwin?
Present in the liver.
Yeah,
Less than 5%.
5%. Okay.
So less than 5% is what is required, and anything more than 5 to 10%, 10 to 20, and more than 30% is what. So here, what do you see, Dr. Ashwin? Can you tell that you are a hepatologist, no?
Yeah, who's doing hepatology?
What do you see in this liver? So you see some steatosis, then you see that the nuclei are pushed to the bottom. What else you see? As Dr. Reddy was telling, there is ballooning. There is ballooning of the hepatocytes. Then, can we have the next slide? You have a lot of infiltration with the. You have a lot of infiltration with the. With lymphocytes. Eosinophils, yeah. Definitely a lot of inflammation is there. You can see the fibrotic strands here.
Yes, sir.
Can we have the next slide? Yeah. Can you read this up?
Yes, sir. The microscopic appearance, section studied of the liver tissue with preserved architecture. The hepatocytes show extensive microvesicular steatosis, ballooning of zone 1 necrosis, and 40 necrosis with satellitosis. Clumping of cytoplasm and poorly formed mammillary dung bodies are seen. Portal tracts show fibrosis, mononuclear cell infiltrates. Interlobular bile ducts are preserved. Minimal focal pericellular fibrosis is preserved. There is no plasmacytosis, granulomas in the section studied. The percutaneous liver biopsy is consistent with non-alcoholic steatohepatitis.
So basically, this was a patient represented with non-alcoholic steatohepatitis and Nash, probably Nash fibrosis or Nash-related cirrhosis. Okay. So only thing was red herring was AMA M2 was positive. We didn't have globulin levels. IgG4 was normal. So this lady probably she had a long-standing iron deficiency anemia pruritus, but her ultimately the biopsy was non-alcoholic steatohepatitis going on to Nash-related cirrhosis. We went back and again checked. There were no granulomas. There were not too much of bile duct injury or anything. So AMA M2 could have been some. Always remember this. Nash can have about 20% of them can always have some autoantibodies positive in this patient. Always remember at least 5 to 20% of Nash could have this thing. She is not obese.
What about anemia? What about anemia?
Madam?
Anemia.
Anemia was looking some more like an iron deficiency anemia. And the CT did not show anything, and that was what we found. And interestingly, I was looking at keratoconus and liver disease. Sometimes some keratoconus can be involved with quite a few of these autoimmune disorders like thyroiditis. It can be associated with chronic active hepatitis, Crohn's disease, all those things I've said. But this lady was predominantly biopsy came as Nash, and we just treated her symptomatically, and then she's much better now. She had pruritus, so was there a probable cause of pruritus? I don't know. It could be chronic anemia which could have caused this pruritus. She was much better after we treated her anemia now. So
what about the values of Nash? No? AST/ALT was also not hugely.
Yeah, she has gone into fibrosis, man. She has gone into a sort of fibrosis now. Could it be drug-induced Nash? Drug-induced fatty livers can come, but predominantly she has not been on any other drug. She says she has not been on CAM, she has not been talking. Only 4 years back, she was given some steroids. We checked whether when she was treated with anemia, was she given any excessive dose of vitamin A? No, she was not given in this. So this is something like a Nash presenting like going on to fibrosis and probably cirrhosis with a red herring of AMA-M2 positive. We thought we will recheck AMA-M2 after 3 months, but in Nash, most of these people could.
In the exam, how should they manage this patient? No? In the exam, if they get this case, what should be the approach?
We just put, because there was melanating bodies, ballooning and all, she requires treatment. She is not a diabetic. So what we just put her on only vitamin E now. And because, we thought we'll just observe her. We didn't want to give obeticholic acid mainly because definitely got pruritus. And we said we'll have a look into her and how to. She's much better after this. This is the case which presented to us. So we were looking at something like autoimmune hepatitis or primary biliary cholangitis. It turned out to be a Nash. And Nash.
VK, in the exam, how should they go about discussing? Supposing this patient comes, no?
In the exam, I still put a primary biliary cholangitis. The biopsy has come as Nash. Then you put the biopsy and we'll discuss this.
Yeah.
So in exam, I think you cannot say Nash, but
Not
I think what we discussed was right. Autoimmune
discussion
with an overlap, PBC, PSC, chronic viral hepatitis. You said hepatitis C and infiltrative disease like sarcoid. It could be lymphoma also. So all those things need to be think. But when we went through this case, this is how the exam goes on. Ultimately, the biopsy will be like this. Then there will be questions on biopsy. How do you explain this? How do you explain that? That's it. We are going to see you overall. We are not going to look at that you have made a big mistake on looking at the biopsy, but how you discuss this?
Approach most important.
I think the approach was correct. We went right to the biopsy and look at our clinical details. It's possibly primary biliary cirrhosis. That's what we thought. 5th decade, pruritus for 2 years, anemia, once ANA positive, blood transfusion, then jaundice now, then slow fetal edema. Everything is fit into chronic liver disease. She's got pancytopenia. She's got varices. And I think the way clinical discussion was correct, but the biopsy was this. If in the exam they have time and they put on the biopsy, you should be indicated in it. You should be able to. HCV RNA indicated in such patients. Yeah, HCV RNA could always be indicated, but HCV RNA would have been indicated if it's been acute hepatitis C. She didn't have any chronic, no risk factors for any chronic hepatitis except from blood. Maybe RNA. But 4 years back, blood transfusion will not produce. If I think it would have HCV, anti-HCV would have been positive by now. HCV RNA positive, negative anti-HCV come in acute hepatitis. So
What was the hematologist's opinion?
hematology, madam.
Did they give any opinion?
We didn't really take about it. We thought this was only.
So bone marrow study you think would have been important to this patient?
There was no
Because
obvious hemolysis. We asked him.
pancytopenia, no? The pancytopenia.
Yeah, clinical pathologist. They said
Actually, this case would be naturally progressing to cirrhosis with portal hypertension, no?
this is Nash, which has progressed to
cirrhosis with
progressed
portal
to
hypertension.
fibrosis. Yeah.
Yeah, no.
Because you can say
varices
portal
also.
tract has shown fibrosis.
Not only that,
And most
there's also
importantly, because interlobular bile ducts are preserved. If it has been some sort of like primary biliary cholangitis, this would have not been there. There are no granulomas. Pericellular fibrosis is there. Everything is there. Mallory Deng bodies are seen. Extensive masculine ballooning. All these are in Nash.
so LBK. What I'm asking is in the presence of varices and in the presence of these.
It has gone into Nash fibrosis or Nash cirrhosis.
F4 fibrosis with cirrhosis with portal hypertension.
No, it will be more than F2, madam. It will be more than
F4.
She's got
It's F4.
F4 fibrosis.
Yeah.
Yes, she's F4 fibrosis, bar cirrhosis.
But no, because portal hypertension is there. Varices are present.
If it is cirrhosis, she'll be in stage 3, stage 2. At least because she's got varices, which are.
Varices, exactly.
So this is Nash cirrhosis.
Nash cirrhosis, exactly. What's the risk of HCC in this patient, Ashwin? What is the surveillance of HCC in such patients?
It's 1 to 4%, ma'am.
2 to 8% per year will be the.
They
2 to 8% per year will be the thing. Somebody asked, is it possible that she had AIH previously and now Nash, sir? AIH without treatment for 4 years, not very able to say. They said somebody said ANA-IF was positive. We don't have any. When you have a quant, we should quantify what is. Please remember that many times in middle-aged women patients, you can have some body positivity. After 60, your rheumatoid factor can be positive in 40% of people. I think you should read this autoantibodies in elderly in Harrison's textbook of medicine. He'll give you a list how many of them can become positive as you grow older. But Nash is known to have some of the immune-mediated markers positive in at least 5 to 20% of patients. This is what is this thing. So this is basically a Nash fibrosis. Probably some chronic ID iron deficiency anemia with pruritus going on for this.
Yeah, I think until the biopsy, I think our discussion was in the classic exam order. That is thinning of polystatic liver disease, which finally evolved into cirrhosis and then decompensated.
Correct.
So the clinical discussion was in the correct line. The only additional point was anemia, which probably we thought could be autoimmune, but it turned out to be iron deficiency. She may be having some other cause for that because she had platinum Nikki also, because even now she has iron deficiency. The other problem is only after the liver biopsy, I think liver biopsy has completely changed our diagnosis. Okay, as somebody has pointed out in such situations, whether we should consider a combination, whether she had a primary biliary cholangitis in the background and now with the superadded NAFL. But I think liver biopsy should have shown some features. Interlobular bile ducts are perfectly normal, so we have no business to diagnose primary biliary cholangitis in this case. So her less pruritus seems to be probably non-hepatic. Okay, because alphos also is normal. Even in intrahepatic cholestasis, there will be some degree of elevation. So alphos seems to be perfectly normal. So this pruritus is probably not related to liver disease. But in the examination, the first diagnosis would be primary biliary cholangitis evolving in
BSC,
and decompensated.
autoimmune hepatitis overlap.
And then they will be also asked various other causes of decompensation, like ACL, whether there's any additional cause for the decompensation that they will have to say. I was wondering whether still it could be some other drugs which probably we do not know whether she has taken any CAM or anything which could produce a picture like this. Because the clinical picture,
we kept asking her, even she came to me day before yesterday, I kept asking her whether she took any CAM. Because there are drugs which can produce Nash, but she said nothing. She was only thing.
Sometimes they may not disclose it all.
Yeah.
That's not about it.
So she told me she's a fairly educated lady. She's a jeweler actually. and she said there's nothing there. But as the Varghese sir said and Jayanti madam, but I think the clinical discussion was right. This is how we go.
Yeah.
If they have biopsy with us, then they will put the biopsy and ask you what you discuss, and you should be able to discuss in such a situation that this could be. So you should be a little more prepared for these sort of biopsies. And how do you turn around the discussion is something which we look forward there.
I think at the level of the liver function test, liver biochemistry, my diagnosis was just switched over that the liver is near normal. You know, it's all near normal, abdomen normal.
I think it has reached a stage of
and
fibrosis.
alphos was normal. So then I would really switch over my diagnosis from something it's not granulomatous, it is not an autoimmune overlap. It almost separates it out that it is something that's more of a normal liver.
Only
You know?
point is,
So, and therefore,
only the point was that probably when even a Nash, they go on for a cirrhosis and all these will turn around a bit. All these things start coming down.
So actually, if the case was with me, like what I would have done, I'm just telling, I was just thinking, I would go for a hematologist opinion for the pancytopenia. Portal hypertension is there. Once he says nothing is wrong with him, then I would go for liver biopsy. And then switch over the diagnosis. Because the liver biochemistry was something very striking that was near normal. With just a rise in the bilirubin, it was again favoring something like hemolytic or a Dubin-Johnson or a Gilbert overlap or something like that. Because AST, ALT was near normal, alphas, gamma, everything normal over a period of 2 years. So is there any role for MRCP in this patient? We will not do. Alphas normal, no MRCP. If alphas and gamma GT was sky high and ultrasound was normal, CT was normal, there may have been a role for a MRCP. So again, MRCP also goes, does not come in the way of your investigation. I think that one case is sufficient for today. Do you have any?
I think if this case is taken to examination, I think they should say primary biliary cholangitis evolving into cirrhosis.
AH, PBC.
There should not be any confusion regarding that.
No confusion.
Primary biliary cholangitis, AH.
Yeah, because the natural history is so typical of primary biliary cholangitis.
Yeah, correct.
Progresses for such a long period and then jaundice at the back end. Yeah.
Then infiltrative liver disease. Then I think whenever you have an the sudden onset thing, I think we should need to think of malignancy also. Sometimes you can have intrahepatic cholangiocarcinoma presenting like this, some of the malignancies, lymphomas, all these things.
Lymphoma, something. And
small T lymphomas are known to present very, very small ring.
All of you, please read out of the box. I think you should read Harris.
Also, Venkat, when I was reading through, I found out a new entity called critically ill patient developing severe sclerosing cholangitis, which occurs in a short period of time, and the decompensates.
It's called ischemic. When you have a severe critical ill, when there's hypotension, what happens? The bile duct undergoes an injury due to an ischemic injury, and they think what is called as bile cast will be formed. So they can develop sclerosing cholangitis because of ischemic cholangiopathy.
So this occurs in critical ill patients.
They can have severe bile cast, they can have severe
and that's
jaundice.
Because,
So apart from ischemic hepatitis, if the jaundice keeps galloping up, you need to think of ischemic cholangiopathy where there will be bile casts actually.
Normally,
that is because it is the bile duct. They always stress supplied only by the hepatic artery. They keep on stressing on this.
This is called ischemic cholangiopathy, especially when you are having hypotension and in a critical ill, you can have this. There are two things in critical. You can have a critical ill cholestasis in liver that can be secondary to your cytokine response, where they can have a canally cholestasis. The second thing can be ischemic cholangiopathy, where you have severe hypotension. Just like ischemic hepatitis, the hepatocytes the bile ducts get injured, and they can have a bile cast actually in that. Sometimes when you do ERCP, the cast will come down, and they can develop sclerosing cholangitis like picture later.
Then another thing is drugs like chlorpromazine, which were taken for a longer period.
There are drugs which can produce sclerosing cholangitis.
Yeah, it can lead to secondary sclerosing cholangitis, and even have a picture which is similar to sort of biliary cirrhosis.
Yeah, you have drugs which can produce phenotypic presentations. There are drugs which can produce autoimmune, drugs which can produce cholestasis, drugs can produce sclerosing cholangitis, drugs can produce fatty liver. All these things phenotypically. I think if they go to this EASL guidance on drug-induced liver disease, they have a whole list where what can produce what. Now, the drugs apart from ATT, apart from they call it as HSD in Germany about the herbal drugs. Then now immune checkpoint inhibitors. Immune checkpoint inhibitors, especially piclomab and nivolumab, can produce jaundice and autoimmune hepatitis. So based on that, you may have to treat them, especially with PDLT4 drugs. You may have to start them with steroids. So these are things which can present like this. So I think I would tell them to read about the EASL guidelines and thing. And please always, there is an app called Liver Talks. Go through the Liver Talks and then you can go through all the toxicity of things. This is, I think, brought out by Mayo Clinic or by Dr. Nagachalasani group, where they are put as Liver Talks and you can see all the side effects of the drugs in the Liver Talks. Okay?
Thank you, LBK.
Okay, madam.
BT, we'll just stop this one case here.
Thank you, sir.
Okay, madam.
Thank you, madam.
Yeah. Good presentation. Please read the histology. You must know what is microvascular, what macrovascular, what are
And
the causes.
somebody said, should we put Nash in every liver disease? No, you won't push Nash in liver disease. But if you are dealing with somebody who's got obese diabetes, then you can bring in Nash. But in this patient, I don't think we would have brought in Nash. We would have just probably, I think the clinical discussion, what you said was right. But incidentally, I had a liver biopsy and I had to put it on this. And
this patient clinically, if there's a Nash, they will end in trouble because this patient had no risk factors of Nash.
Exactly.
Nothing. No, our clinical diagnosis was actually biopsy. We said that it was a primary biliary cirrhosis, and then we should we did the biopsy. We did not expect Nash. So I said then we need to follow her up and see. She'll be irreversible because she's already got portal hypertension. So we need to keep her on surveillance, and she decompensates further. I think we need to transplant. That's
and the surveillance for F4 fibrosis is similar to HCC, it's just monthly alpha
she's
fetoprotein.
already cirrhotic. I think we will put her on every 6 months of
alpha fetoprotein and ultrasound scan.
And hepatology residents, please read about abbreviated MRI for screening of HCC. Abbreviated MRI.
You can just tell a few words about that.
As against the ultrasound.
LBK, just tell us a few words on abbreviated MRI.
No, abbreviated MRI, instead of doing a signaling, they said abbreviated MRI, where they can, it is known to look at diffusion restriction much better, and probably also look in pickup rate of, especially by a 1.5 Tesla machine of a small lesions, is much better than an ultrasound. So, and it can also give you. The second thing is, in a Nash now, there is a new MRI scoring called the MAST scoring or something, MAST scoring. Kindly look into that. That is, if somebody is on Nash, got a Nash like this, and you want to follow her up. Say, here this patient is cirrhotic, but if you have a patient with Nash, your biopsy shows only ballooning, which shows only spotty necrosis, it shows only no fibrosis. Then there is FIB4 score, which will tell you the progression, but also there is one MRI validated score called the MAST score. That also now is being coming into the vogue, and they found that's probably will on surveillance to depict whether this is going to fibrosis or not, may add on to this FIB score. So that is something which I think it has come already in January 2022. So they might ask you in the exam, in hepatology exam, what will be your read through all the EASL guidance of non-invasive assessment of liver.
Yes, sir.
Okay, so it is in patients with how do we look for fibrosis? How do you look at the progress of fibrosis? That is given all these things now. Okay.
Okay, sir.
I think hepatology, all the review articles and hepatology snapshots which comes in. Do you read Journal of Hepatology?
Yes, sir. Yes, sir.
Do you read hepatology? Who are all the hepatology residents here? You should look at the snapshots. Okay, there's what is called as hepatology snapshot. It will give you everything. Cholangiocarcinoma. It will give you the phenotype. It will give you the risk factors. All those. So even if you write, if you have a cholangio, if you write on a snapshot, everything. So go through all the hepatology snapshots. All open access, and you can.
This is of Journal of Hepatology, no?
Madam, Journal of Hepatology. Journal of Hepatology.
Yeah.
Not the hepatology. Yeah. Journal of Hepatology. European journal.
Journal of Hepatology is free.
and they should read up all the thematic mini-series. In thematic mini-series, they'll have HCV relapse. There'll be a short article. Okay. HCC in post-HCV SVR. So there may be a few things like that. So you should read up all those things. Keep ready.
What's the website for the snapshot?
Sir, last I
Hepatology
didn't get,
snapshot
sir.
will be on diagrammatic representation of a problem, madam.
No, snapshot.
So if you have hepatic,
website, okay.
Just Google it.
It comes in Journal of Hepatology. There will be one page of
Hepatology snapshot.
1 minute.
Journal of
1 minute.
Well, that will be interesting. One of those speaks.
See, it will come like this. Okay, it will come like this. This is a paper of hepatology snapshot. Here, this hepatology snapshot is malarial parasite in liver. So there will all be diagrammatic representation of this completely.
Okay.
Easy to remember. Yeah.
You have a diagrammatic representation. What is C-cell priming? All those things.
No, so we just type the snapshot.
I think if you go to hepatology, this is the Journal of Hepatology, and there'll be some of them are open access, so they can
open access. Okay.
So
and the second, they were asking for the second reference you mentioned, thematic. What's that?
That is in the review article there'll be what is called as thematic mini-series. They'll tell you, they'll just have a small article, HCC in full. Then hepatitis C retreatment.
Some of them you can send to us, LVK.
Yeah, sure.
Yeah.
I think I can access it. So.
In the PG clinics, if you can just send it, no?
I'll do that.
Go to that. Even some important snapshots.
Yeah.
Quick reading. The PG
I think I have just 1 minute. I'll use the 1 minute.
We can just, it will be easy for us also.
So we will have the postponed class next Tuesday. Last Tuesday I had some technical problem. I couldn't log in.
None of us could log in.
Yeah, there was some Zoom issue. Yeah.
Yeah.
This is what happens. So
Google Meet seems to be safer. You can ask your people to switch over to Google Meet. Clarity is also there. This is the thematic. Oh, this will look up here. Yeah.
Many thematic series, there'll be expert reviews, and other thing you should read is Journal of Hepatology is the clinical grand rounds. That's excellent, actually. Clinical grand rounds. They just take alcohol, liver disease, and then.
Thank you, LVK, for the wonderful session. Thank you. Okay. It was really interesting. I came out with something very common.
Which, madam?
It started in a big way, but came out as a fatty liver.
No. Yeah. The message is like that if we have a biopsy and we put forward the biopsy, I think then we'll end up the discussion.
See, unlike there is an important thing. Unlike alcoholic hepatitis, where there is a cholestatic phase, the Nash doesn't have that cholestatic phase. Doesn't have a cholestatic phase. So none of the students should ever make that statement. This cholestatic
and jaundice
doesn't have cholestatic.
And jaundice. Yeah. And jaundice. There's no jaundice also. No jaundice, no pruritus. Pruritus is diabetes.
The only worry will be if it decompensates, she decompensates faster. That's the bad thing about Nash. And if she gets a HCC, she'll get a big HCC. Yeah. Oh, that is a problem with us we have.
Yeah, that's true. Yeah. Thank you, everything. Thank you.
Okay.
Thank
I think next we'll do it. When do we do it again? July.
Yeah, July sometime. We'll sort it out. No problem. Maybe the second week.
We do it again on July
16th or something.
July 7th.
7th is second Thursday.
Yeah, second Thursday.
Okay,
July 7th.
Okay. Yeah.
So anyway, I think July 2nd, you can probably do the delay what you have.
Yeah, drills is there, no? First, second, third.
Yeah, that is drills. 7th July will be.
7th will be, sure.
We'll meet at 8.
Yeah, sure. Thank you, LVK. Thank you. Good night. Thank you all. Thank you, Ashwin, and thank you, Sachin. Thank you.
Thank you, ma'am.
Thank you, Vicky.
Thank you, ma'am. Thank you.